Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Sean Cullen, who is a licensed professional counselor and has over 19 years of experience working as a mobile crisis screener in Morris County, New Jersey. I wanted to release this podcast because Sean describes how to effectively work with law enforcement when dealing with mobile psychiatric crisis situations in the community. Sean is also a mental health clinician at Morristown Medical Center, one of New Jersey's best hospital systems, and actually took over my job when I left the hospital to pursue my doctoral work. Sean, welcome to The Therapy Show.
Hi, Bridget. How are you?
I would like to highlight your experience working in mobile crisis teams. For those who are not familiar with this term, mobile crisis refers to a group of health professionals, such as mental health clinicians, nurses, and psychiatrists, who respond to mental health emergencies in the community. Sean, from your experience working in mobile crisis, what are some of the main reasons someone would be assessed by a mobile crisis unit?
Well, I think obviously the most common reason, unfortunately, is, usually an individual is experiencing suicidal thoughts or suicidal ideation, and either they've expressed that and contacted a crisis or screening center looking for help, but may not be willing to come into the center or the crisis center, or a family member, they express this ideation to a family member or friend has become aware and contacts a crisis center or screening center, resulting in mobile crisis getting involved to assess this individual. And some other secondary reasons are not secondary in that they're less important, but maybe less prevalent in terms of what comes to mind initially when asked that question is, if someone's experiencing acute thought disorder symptomology, so someone's experiencing acute psychotic episodes, where they're becoming impacted in their daily life, and again, loved ones and family members, usually more common in that occurrence, or police, or school systems, college, universities, places of employment, other hospitals would call to seek further assistance in assessing and hopefully stabilizing these individuals during these periods of acuity. Other reasons might be acute mood disorders, especially more maybe manic symptomology, again, where an individual's insight may have been blurred due to their acuity, and now it requires the intervention of the crisis staff, the screening staff, to get involved on a community basis to help stabilize and bring that individual in. Lesser versions that you can get called, there are quite a few calls involving substance misuse, where an individual who is either in the instance of being under the influence of a substance or possibly coming to a withdrawal may make statements or be acting bizarrely or aggressively. And again, family members, loved ones, individuals in the community, police may contact screening to have an intervention done. And in terms of getting the staff to come out, the individual's unwilling to come to an ER crisis center to be assessed at that time. There's also quite unfortunately common calls for domestic disturbances, where one party may have made statements about threatening the other party or threatening to harm themselves, again, in reference to suicide or a statement that could be construed as suicidal, and officers on the scene may call out to mobile screening to come out and get involved. And again, if that individual is unwilling to come to the ER or appropriate crisis center with the police at that time. So those are some of the more general reasons that screening will get called, I would say. There's obviously always various reasons and ways that screening gets involved, but those are probably some of the larger areas.
And community is prioritized over other levels of care, am I right?
That's correct. So I guess we should spend a moment or two clarifying, what is actually mobile crisis. And in New Jersey, there's technically two levels in New Jersey. There's adult and there's children. Generally, what we're talking about here is more adult. Children is different for every county, just depending on the entity who runs it, whereas adults are usually run by screening centers in various counties. So you're correct in that if a screening center receives a call of an individual out in the community, a home setting, shopping mall, parking lot, even a police headquarters, those calls for response would get answered first prior to someone who's in another ER that needs a commitment or a commitment evaluation, or someone who is on a medical floor in another facility. Those would be secondary to the initial response of the community. Those would be the primary areas that get responded to first.
What might a person expect to happen to them while being seen by a mobile crisis unit?
Well, that's a really good question, because I think a lot of times when family members call, There's a bit of confusion exactly, again, what is mobile crisis? What is a mobile screening response in the community? Generally, when screening is called, the purpose is because the individual is perceived as possibly being in a state that's resulting in an imminent risk of danger to themselves, others, or to property. Now, obviously, it's difficult for family members to really assess such, or even police or other professionals. But the idea is that when mobile crisis or mobile screening gets called, they're responding because the belief is that there is such an imminent risk that they need to get involved. Sometimes family members will actually call for what seems to be more like a mobile intervention. Someone's having difficulties either with substance abuse or someone's having difficulties with a mood disorder, and the family wants someone to come out and do more of an intervention, and that's not the role that mobile screening plays. So when mobile screening does come out to the community setting, they almost always come out with responding police officers. And the reason for that is because you're entering an individual's home setting, or you're entering a setting that has a lot of unforeseen variables. If it's a parking lot, if it's a work environment, where an individual who may not want to, most of the time, come back to a crisis or screening center, and now you're there to essentially assess them in that setting to see if they meet the criteria under the screening law to be brought back to that setting, to be brought back to a screening center or a crisis center. And sometimes when you make that determination, the individual is not very pleased with that recommendation. And therefore, that's why police officers are asked to come out. So it can be very overwhelming at first to families and to the individual, because when mobile crisis arrives, it's usually one or two screeners in addition to one or two responding police officers. The goal is not to embarrass or create a scene for the individual, but it is to ensure the safety of the individual, the family members, people in the surrounding community, as well as the screeners that are responding. So when they arrive on the scene, the idea is to have the officer secure the scene while the screener interacts predominantly first with the individual, sets a rapport with them, discusses with them what's going on. Then second to that, might speak with the family members shortly thereafter, and then speak to the individual a second time as needed to clarify things or to verify different accounts. From that point, then, the screener would be, or crisis responder would be required to contact back to the attending psychiatrist to review the case to see if the individual requires to be brought back to the hospital. Now, in the instance that the person wants to return to the hospital, that makes things slightly more simple. Usually an ambulance is called and they're brought back to the crisis center. In the instance where the individual does not want to return and there is deemed an imminent risk per that review with the psychiatrist, then they can be brought back against their will, which, again, the crisis worker tries very diligently to make the resistance less severe so that the individual is sort of in agreement to come back. In the case that they're not, an authorization for transport can be signed to take the individual against their will. So the goal here is not to create a scare tactic or make families or individuals who are in need frightened to say, if I make this call, the police are going to show up with some individual who's going to pull me out of my house and take me against my will. That's really not the goal of these assessments. The goal is really to assess if there is this risk and if there's something that can be done to help this individual through this crisis so nothing happens to harm them or someone else because of a result of the current acute state they're in.
So what are some of the possible scenarios a person might experience while interacting with mobile crisis?
That's a good question. I think it varies specifically, especially in the setting. So in a community setting, it's sort of unusual because, there's some individual you don't know showing up at your home, usually almost always with police officers, and now they're asking you possibly very personal details of your life because maybe family members already informed them or made a previous phone call to get mobile crisis, mobile screening involved. So the idea really is for the screening evaluator to try and build some very quick rapport with that individual. The goal is not to come there and judge that individual and say, well, you're unfit or you need to return to the hospital. The goal is really to advocate for them to say, there's people around you that seem to be very concerned, and I'm not disavowing what they're saying, but I want to really hear your version of the story and hear your side of things before we make any decisions. So that is the primary goal of the screener in the community setting, to ensure some type of rapport, ensure some type of safe way to transfer or safe determination for that interaction. Mobile screening in a hospital or ER setting is a bit different because you're kind of coming in maybe second, third, or fourth party that has seen this individual, whereas they may have been seen by that hospital's own crisis staff, by their own psychiatrist or advanced nurse practitioner, by their own therapist. And now you're coming in essentially just to determine if this individual meets the commitment standard under the mental health screening law for New Jersey. That can be a bit more difficult in the sense that the individual at that point may be sort of exhausted from explaining themselves and they may be more frustrated. So again, your goal is really to build a very quick rapport with this individual and try to express to them that you are there to sort of advocate for them as much as possible while determining underneath the guise of the law due to clinical factors if they need further stabilization. So I think the idea is that what I would really like to impart to people is that mobile crisis and mobile screening, the idea is not to scare people. The idea is not to present as imposing laws on people to take away their rights. The goal is really to help individuals, and if it does go the route of an involuntary, to still try and maintain their humanity and their personal aspects, and to try and make that whole process as to remove the level of displeasure and unpleasantness as much as possible.
What do you think are the positive aspects of mobile crisis?
I think there's twofold. I'll go twofold with that. I'll go one that's more selfish in the sense for the clinical worker. I think it's an extremely invaluable skill that is not taught in any graduate classes, that is not taught for people who quickly go from grad school right to private practice. It really teaches you to make very sharp, astute assessments in a very short amount of time. It teaches you to de-escalate very tense situations, to be able to read family dynamics very quickly, to be able to build rapport in a way to mitigate and de-escalate potential conflicts. And I think it's an invaluable skill for most clinical people that they should at some point in their career take they have an advantage to undertake that training and do so. I think for community and for individuals, I think it serves a purpose. It's a twofold purpose. One is that I do think it allows individuals who really are in need of help, whose insight and judgment has been skewed because of the acuity of an associated presenting issue, that when they're unable to get that help, it allows for a professional individual to step in and aid them in getting the appropriate level of help at that time to avoid any potential catastrophic outcome. I think the second aspect of that is that they do at times function, especially in other hospital settings, as really a sort of secondary advocate for these individuals, where possibly due to a bad initial assessment, and bad in that maybe it was bad meeting, maybe the initial crisis evaluator came and the patient was quite irritated or agitated, and the crisis staff was quite curt or tired, and they had a bad interaction, and it led to a very short terminated interview, and now the decision's been made, I can't really interview this person, they're not helping me to see what's going on with them, they need to be put into the hospital, and now a mobile screener comes and has a secondary chance to re-engage this individual and advocate if they really don't need to be put into the hospital on an involuntary basis. So I think while it has, generally it's viewed as a much more negative, scary sort of outcome and interaction, I think there are positives within that interaction for both the patient and obviously for the clinical individual.
What do you think are some of the pitfalls of mobile crisis?
I think obviously for the individual being evaluated, the potential of having your rights taken away from you is a foreign concept for most of us in the United States. The idea that individuals can show up at your home and essentially have you escorted from your very home due to reasons that you may not see as valid in that moment can be a really terrifying, frustrating, and aggravating experience for an individual. And it really strips a person of their sense of self and their rights. And I think it can have a really detrimental effect. That's where I think rapport building is such an integral part of this process. Because if the mobile screener doesn't have the ability to build that appropriate rapport, you can in the initial do more damage. It's still, even that damage is superseded by the aspect of safety of getting this individual to the appropriate safe level of care. But that is a definite pitfall for this entire process. I think the second part of that, going back to the clinical staff, is it can be hard. It can be hard to take an individual's rights away. It can weigh very heavily on clinicians to do such a thing, because generally you get into this work because you want to help people, you want to work with their resistance, you want to build rapport and trust and move forward at their pace. And this is sort of the antithesis of that. It's sort of you're making a determination of the ultimate level of taking this person away from their life in that moment and sort of enforcing treatment upon them. And so it can weigh heavily, I think, on clinicians as well.
Can you share one of your most memorable patient experiences without giving away any identifying information while working on mobile crisis?
Sure. There's two I can actually talk about without really giving away. One was very early on in my screening career. I got called, sent out to a residence. It was an individual, a family member called. An individual was presenting with really acute mood symptomology, seemed to be elevated mood symptomology as well as some thought disorder symptomology. They had been spending excessively, somewhere in the high thousands of dollars in a period of 2 to 3 days, weren't sleeping, agitated at home, argumentative with the family. I arrived with police at the scene of the house. The individual who called didn't mention that there was a family gathering. So when we entered the residence, there was the individual we were called to see and about 15 family members. And out of the 15 family members, only one was aware who made the call. The other 14 were not aware and were not excited to see us. And in the process of me telling the individual they had to return to the hospital and the family, arguing with me that I couldn't do that and telling them the screening law and that they had, at this point, there was an authorization signed, they had to come back to the hospital. The police responding officers tapped me on the shoulder and said, "We have a call, we'll be back," and left. So there I am standing in this living room with these 14 family members who are now agitated with me for telling me I'm taking their loved one out of their home against their will. The police are gone, and it's just me standing there with a piece of paper. So that was certainly a memorable experience, that one. And talk about bad timing. The second one, which is a much nicer story, is there was a time we were called up to a hotel by police. There was an individual there who had been acting somewhat bizarre per the police report. We arrived on the scene, myself, the officers were already there, a colleague of mine. We spoke to the individual. The behaviors, while possibly bizarre in the community setting, so to speak, were nothing that were presenting as an imminent danger. They weren't harming the individual, they weren't harming people around, there was no damage to property. So under the law, there was no reason to bring this individual back. My colleague continued to talk to the individual. He felt that it would be good for the person to come back for reasons that he didn't have a definitive clinical reason in terms of danger or risk, but he said, "I just think we should bring this person back." He spoke with the person agreed to come back to the ER. When we got back to the ER, about maybe 20 minutes after being there, the individual suffered a significant heart attack and was able to be revived in the emergency room. Oh. And the medical team said, had we not taken this individual to the ER, he probably would have succumbed to the heart attack in the hotel because there was no one else around. So my colleague, that's all to my colleague's credit, because to me, and this is where you can get blinded as a clinician, to me, he didn't meet the standard of the law. He initially didn't want to come back. There was no grounds to force him. But my colleague, through building rapport and thinking what was in his best interest, spoke with him and motivated him to come back. And it actually ended up he was fine. He actually was discharged about 2 weeks later from the hospital. So it had a happy ending in that story.
That's an incredible story. That really is.
Yeah.
What are you most excited about in mental health treatment today?
I think what I'm most excited about is that there's a return to therapy. I think more people are embracing actual therapy. I think even larger outpatient programs are starting to understand that partial hospitalization and intensive outpatient models, while they serve a significant purpose, are possibly being overdone or overprescribed, and that people are starting to see benefits in individual therapy, in real group therapy, again, not just groups throughout a day, but actual group therapy, and that there seems to be a real push within the therapy community of individuals going back and getting further training and certification in specific forms of therapy versus what seems to have been for years a sort of eclectic style that I really think has kind of watered down the field. And in my opinion, I'm sure I probably aggravate some people saying that, but that's my opinion. But I just think it's a nice time. I think people are really sort of engaged in their mental health in the general community sense. I think stigma has been taken off of it. I think it's a great time to be an advocate in this field. So that's the stuff that really gets me the most excited right now.
If you had a magic wand and could improve one thing about mental health treatment today, what would that be?
Accessibility. We just do not still have an easily accessible mental health system. Even if you're private pay and you have money and you could pay out of pocket to see a therapist, it's still confusing to find therapists. I think Psychology Today has done a good job with their own search engine of being able to find a lot of therapists, but it's a very difficult field. For people who are in crisis or heading into a crisis, I think it's a terrifying, confusing maze to navigate. I think we do a poor job as professionals, even at the highest level, administrative levels, of really opening that door and showing people access. I also think because modalities are slow to change, we've had sort of the same treatment modalities for many, many years. So people who are in crisis get admitted to inpatient units, and inpatient units refer to partial hospitalizations or intensive outpatient because there really is no in-between. And the lag of getting individuals connected with services results in this sort of revolving door at times because we really can't engage people on a really meaningful level. So I think accessibility would be the one area, if I had a magic wand or the miracle question of a wish I could change things, that would be where I would target, would be accessibility.
And that's what we're trying to do here with this project. So Sean, on behalf of myself, my listeners, and all of the people you have helped through your work, I want to thank you for your contributions to mental health treatment.
Oh, thanks. Yeah, I appreciate it. I'm glad to do this. I like doing this stuff. Not that I like to hear myself talk, but I certainly like anything about dialoguing about mental health. It's definitely needed. So thank you.
Well, it definitely shows that your passion for helping people. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so that you, someone you love, and people around the world can gain more benefit from treatment. There is no need to suffer in silence. Get the help that you need to build a life that you want.